we go. Welcome to the webinar, Teaching Oral Presentation. I'm Barbara Lewis, and thank you for joining us today. This webinar is going to last about 30 minutes. And if you have any questions, you can type them in the Q&A box. If we don't have a chance to get to them during the webinar, we will respond afterwards. But before we get started, let me talk briefly about .com. So .com is a proven online interactive healthcare communication learning system, and it's an interactive platform. We have 42 multimedia-rich interactive online modules, over 400 realistic videos, and all the surveys that we've done, people love the videos because they can watch what happens, they can listen to what happens, and then we have annotated videos so that they can actually read down the side of what particular communication technique is being used at that time. The module authors are leading faculty, and we have a back-end learning management system. We've had over 100,000 subscribers in over 300 institutions. We've been translated into 3 languages in 20 countries. We have our subscribers. We also have 10 journal articles about the value of .com. And here are some of that research, which is on our website that you can take a look at. The sister platform of .com is Professional Formation, and we have 12 modules on professional formation and 2 faculty modules, faculty development and remediation. So I'm going to stop sharing my screen now, and then Lauren is going to share her screen. So joining us today are 3 authors of the .com module on oral presentation. Dr. Michelle Birch is Assistant Dean of Curriculum at Wake Forest University School of Medicine. Dr. Lauren Fine is Associate Professor at Nova Southeastern University College of Osteopathic Medicine. And Dr. Vijay Rajput is Professor and Chair of Medical Education at Nova Southeastern University College of Allopathic Medicine. So thank you, Lauren, and I'll turn it over to you.
Thank you. Does everybody see the screen okay with the presenters listed? Okay.
Yes, we do.
Thank you so much, Barbara, for having us. I wanted to say I'll be starting off the discussion. I think we may have some poll questions. I don't know if Barbara has them ready for now. Or
yes, I do. Do you want me to launch?
Sure, go ahead. We just wanted to get an idea of our audience so that we can make sure that we touch on some points that fit the audience. So the first survey question is, where do you spend most of your time teaching? Outpatient setting, inpatient setting, classroom, or other?
So they're all together, Lauren, so
okay.
People can go,
go
down through all of them.
Sure. We wanted to know who the learners are that you work with the most. You can answer any of them, all of them. So MD students, PA students, interns, or residents, or more than one. What section of the oral presentation do your learners struggle with the most? The HPI, review of systems, physical exam, assessment and plan, or another part? What aspect of the oral presentation do your learners struggle with the most? Organization, content, delivery through verbal communication, or delivery through nonverbal communication? And when do you believe the oral presentation should be introduced to learners? First year in early preclinical, second year late preclinical, third year early clinical, or fourth year late clinical. And we chose the alternate option of early and late preclinical and clinical because we know that some students may not have 4 years of school depending on what program they're in. So you can modify that based on what your learners are. How often do you ask your learners to give an oral presentation at the bedside? Never, sometimes, often, or always.
So it looks like we have a lot of people who participated. I'll end the poll now, if that's good for you.
Fantastic, sure. All right, so it looks like we have a wide variety of where people spend their time teaching, good variation there. Learners, same thing, so mostly MD students and residents, but a good number of PA and interns and others. Assessment and plan is the area that most people have difficulty with. HPI seems to also be one, and I think I could agree with that. What aspect of the oral presentation did your learner struggle with the most? Sounds like organization and delivery, especially verbal communication. We'll talk about each of those, but I think that that's a common thread. When do you believe the oral presentation should be introduced to learners? I see first year, early preclinical, and second year being most common. Some did say fourth year, at least one person. How often do you ask your learners to give an oral presentation at the bedside? It sounds like most of you do it. A couple people have said never, and a few people also said always. All right, thank you for that. Thank you for participating. We really appreciate it. So I'm going to ask Dr. Birch and Dr. Rajput to chime in at any point during this. And if there, I don't know, Barbara, if you want anyone from the group, if they have questions, to put them in the chat while we're speaking, or if we should save any questions for the end. If you could
Sure, that's up to you, but
okay. I'm happy to answer questions as we go. It's sometimes easier. All right, so we'll talk about our learning objectives for this. We want to identify the key delivery principles of effective oral presentations for the learners. Convey learners, teach you to be able to convey your learners the appropriate content, organization, and length specific to the clinical setting for the oral presentation. Recognize common problems that decrease presentation effectiveness and how to remediate them. And lastly, we'll demonstrate the use of different tools such as SBAR, IPASS, and SOAP, and talk about when each one might be appropriate for the learner to use. Some key principles of excellence. Very good or excellent presentations are tailored. They're not necessarily checkbox or very prescriptive. They have to be adjusted based on several different things. One, the setting, whether you're in the inpatient setting or outpatient setting, you may focus on different things. You may have to spend more time on particular parts of the presentation. The audience that you have, so if you're speaking to your own group of internal medicine doctors or surgeons, or you're speaking to somebody from another specialty, even interprofessional communication or rounds, that might mean that you tailor the way that you present, what information you present, the organization differently. The urgency of the situation may alter the order that you present information in, or the type of information you present, or even the emphasis you give on certain items. And the clinical situation, whether you have a new patient, it's a follow-up, or you're transitioning or handing off, may alter what is provided, the organization again, and the emphasis. We do usually use a very standardized format for oral presentations. I think all of us use a very similar format. If we were to talk about this as a group, we would probably agree on the order in general, the content in general, and what should be included or what would be important. However, everybody's a little bit different. Everybody has a different style. So it's important that the learners or we clarify expectations with one another prior to the presentation being given, so that they can ensure that they're providing the right information to us from the beginning and they know what we're expecting. The things that we want to clarify and make sure that they know are, what is the content we're looking for? What details are we going to always ask for if they didn't include it? So they should always make sure that they do include it. How much detail do we want? How much time are we going to be spending on this? Is this a 5-minute presentation? Is this a 1-minute presentation? So that they know how much detail to go into for the presentation overall, but also how much detail to give in, for example, the HPI or the physical exam. There may be just certain items that are being expected to be provided unless they're asked for. Key principles for effective delivery also include enthusiasm in speech, using the right inflection, the right emphasis in certain areas, having good eye contact, but also there are other non-verbal methods that can be used to improve communication. as well as verbal methods. So again, inflection, pausing at the right time, including the other members of the group in the conversation at the right time, or even the patient. We do encourage learners to practice, and practicing at the bedside, is important, and getting feedback at the bedside is important, but they can also practice at home. They can practice in front of the mirror, they can record themselves, they can practice with somebody else on the team before they present, get feedback before they present to the whole group, maybe a colleague, another student, or another resident. Presentations show us what our students or our learners know. It also shows us what their skills and their attitudes are in various different areas that we are assessing them on. If a presentation is not effective, the group may not know what the learners are thinking, and errors can be made. It's sometimes difficult to know whether somebody doesn't know the information or they just don't know how to organize it. So teaching somebody how to organize the information and knowing it's organized well, or that learner knows how to do that, can help us differentiate their knowledge gaps from their presentation skills. Very good presenters will ask for feedback and advice on what went well and what can be done differently to improve the next time. So those who, maybe ask for information about what's expected of them at the beginning may ask again, how did I do? Did I achieve what you were looking for? Or is there something I can do differently for next time? We talked a little bit about listener curiosity and engagement as far as eye contact and verbal skills and inflection. I think also the way that we organize the information can also help somebody be engaged in the presentation. So if you provide the right information at the right time, the right amount of detail, that can help others understand, what's important, and can also help them understand how you got to where you ended up. So if you provide specific details, we can follow along with you. And we're already formulating our differential diagnosis along with you. We're reorganizing our differential diagnosis as you give us more information. We're almost expecting to hear certain information coming. And then when we hear it, we think, okay, yes, that's what I was looking for. Now I think it might be this or this. A very good oral presentation will very succinctly tell a story. We don't want to spend 15 minutes rehearing the whole history as it was gathered. We want it to be reorganized. We want it to be adjusted for who's listening, what the context is, what's the situation, what's happening, who is receiving this information, how urgent is it, and what type of care plan might need to be taken. Is this something that needs to happen right away and it's related to the urgency? Or are we going to spend a lot of time talking about the disposition of the patient? It needs to be chronological so we can connect those dots, right? We talked about all those things that are important for the learner to be able to follow along and say, I have the right information, but it has to also follow a storyline so that the learner, so the listener can actually say, yes, I understand what's happening. I can imagine this happening in my head. And then it needs to have the right data to be able to support what their assessment and plan is. An effective oral presentation also captures the most relevant details of the story. So we talked about those areas that you all said that you thought were important, and I saw that history of present illness was thought to be one of the most important areas, and I agree that's where all those details are so important for somebody to include, and where the chronology is so important. Past medical history, of course, is also important, and we need to teach our learners which portions of the past medical history need to be presented. Is it only that's relevant to this case, or do we want them to teach us or tell us everything about this patient, and then we will filter it out for them? Social history, especially as it relates to the problem that's being presented. Family history also, same thing, what is relevant to this particular story? So teaching our learners what is important to filter out and to present as it relates to the case is important. Physical exam, labs and radiology also tell us a little bit about what's happened with this patient and what we've gathered so far to support what the assessment and plan is. There are various different types of oral presentation. We talked about, handoffs and, inpatient versus outpatient. So it really depends on the type of situation that you're in. If you're inpatient on attending rounds, usually we want it to be 5 minutes or less. It really also depends on the specialty. Some specialties are going to have even shorter presentations. For example, if it's surgical emergency room, it might be shorter. Outpatient clinic, again, might be shorter just because the patient may have fewer things going on or may have a shorter HPI to present. And then if there's a shift change or a handoff, it may depend on the service, what their expectations are for what is included in a handoff. SBAR is a tool that we want to introduce to those.
I was just going to stop here and
Please.
summarize what you said quickly. So what Dr. Fine said is the most important is for faculty US to have a clear expectation what you want from the learner. That's the most, because as you heard from Dr. Fine, there are a lot of different varieties of AU presentation you can hear. That's one. So you set up as a faculty. Now here is a challenge. If you are in a clinical care and a patient belongs to you, then you are playing a dual role in the oral presentation, because your role is diagnosing the patient and diagnosing the learner. And that's a dual task, can be difficult and challenging. So keep that in mind. It's a little bit different when you are diagnosing patient and diagnosing the learner. And both require a little bit different task and a quality. Here is another challenge sometimes comes up, whether you are the faculty who like to probing question while the learner doing presentation and stopping in between, or you're going to allow him to do the complete presentation and don't probe in to his cognitive reasoning. I will leave it up to you to make that decision. But when to do a dual task, you have to figure it out what role, because you are diagnosing the learner and you're diagnosing the patient. And diagnosing the learner is sort of looking into that verb, what Dr. Fine has said. I'm stressing again, the verbal skill, non-verbal skill, delivery skill, inconsistency. And if you're doing with other learner, it may be the point, it's good opportunity to make it clear for everybody so they can understand. So the clear expectation upfront is very important, and dual task, you need to figure it out how you manage that, diagnosing the patient and diagnosing the learner.
Thank you, Dr. Rajput. Actually, I'm grateful for you stopping for a moment because we actually have one other poll question we wanted to ask. I don't know if Barbara, you can throw that in.
Yes, let's see.
So,
Launch that.
Yeah, I can read off the question. It was, how often do you set expectations for the oral presentation for your learners before the first time they present? So before we move on, I wanted to know how often you'll do that. So it would be never, sometimes, often, or always. All right, so I see a lot of people sometimes do it, and I'd be curious to hear from some of you at the end why, why there it's sometimes, is it based on the situation of where you are, who you're working with? Maybe it's the first time you've seen a particular learner and that's when you do it, but then when you've worked with them already, you may not. I'd love to hear that at the end if we have some time. So we're going to move on to how to use SBAR. SBAR is a tool that's commonly used in nursing. And the first time that I recognized that SBAR was a thing was actually before I even knew what SBAR was. Every time a nurse would call me and tell me what was going on and ask for my help with something, I would hear it in this format. And so when I was able to start teaching my students using SBAR, I realized it really helps them organize their thoughts before they present. So we're recommending SBAR as a tool when you're calling an admitting physician, that you use SBAR to present what's going on, so you can provide them with the relevant background. So SBAR just stands for Situation, Background, Assessment, and Recommendation. Situation is mostly, who you are, where you are, who the patient is, where the patient is, and what's the problem. Is this an acute issue, patient has chest pain, how bad it is, etc. Background is any other information, such as maybe, when the patient presented and what's happened so far, or what recently happened, they just had a procedure, whatever else you think is relevant for them to know to process this information, and what you think is going on, and what you're asking for that person to help with. So if you're going to call that admitting physician, or you're asking somebody for help, it's a way of presenting the patient that's not the standard oral presentation that we think of, but more in an acute situation, or I need your input on this, I need your help, and this is what I think is going on. And it allows the learner to also make an assessment and think about what the question is that they're asking, or I think this needs to be done, or I need your help, I'm not sure. When you use an SBAR for emergent situations, you need to make sure you're using the right help. So a student may need to, have a resident help them, or someone else get involved to make sure that whatever is being presented includes the right information. So communication doesn't get lost and it gets misinterpreted as far as how urgent something is, or certain details are not included. In an emergency, it may be helpful to include the S and the R first, so the situation and the recommendation, and then give more information later. For example, how severe something is, how urgent something is, and I think you need to come in immediately because this is what I think is going on. And then, if the person that's listening to this presentation needs more information, they may ask for that information, and that would be the B and the A. An example of how SBAR would be used would be for a situation. Dr. Fine, this is Sharon Smith, a PGY1 calling from the ER. I have Mr. Jones in room 5, a 42-year-old man who looks anxious, is complaining of chest pressure, which is not completely resolved after sublingual nitroglycerin. A little bit of background on him. He has a history of hypertension, diabetes, a strong family history of coronary artery disease. He was admitted for an MI 2 years ago and had a PCI for 1 vessel. I don't have more details on that at the present, but I can tell you his vital signs are blood pressure 90/50, pulse of 120. I think he's having acute coronary syndrome, and we can't rule out an MI, but we don't have a troponin yet. We may need to take him to a cath lab for intervention. I'd like to get a bedside echo and labs, and I think we should possibly alert the cath lab. So that way the resident can convey, the most relevant details, what they think is going on. You have an idea of the urgency of the situation. And then more questions can follow after that from the person who's been presented to if they feel like they need more information. Essentials of requesting consultations are that the learner should gather the data that's relevant to the medical issue in a proficient manner and be ready to present that information. They should be able to synthesize that data. So sometimes they may need to think about it before they present and make sure that it's presented in the right order, the right emphasis is being conveyed, that they're able to relay the problem, give a very succinct differential diagnosis, and then suggest a working diagnosis if the diagnosis is not clear. They should be able to ask a specific question or reason for consultation. So if they're asking for help from somebody else, they need to say, the reason I'm asking for your help is this. I would like you to help me with this or answer this question for us. They should provide contact information for themselves or whoever would be responsible for that patient so that the consultant knows who to contact when they have seen the patient. And the oral presentation should flow. It should be very organized, but also succinct so that it provides the right information in the right order and allows for the person who's receiving it to process that information without extraneous information coming in. I'm going to pass this on to Dr. Birch, and I will control the slides for you, Dr. Birch.
Thank you. So now that you are the admitting physician, is thinking about as ourselves, the admitting physician, the admitting lead in whatever health profession, much back to VJ's point, we are doing a dual task often, right? So one of the most important things that I have found in telling my learners up front is that you are my eyes and ears. I am the leader of the team, and so I am responsible at the end of the day. So if you're my eyes and ears, I want you to create that organized format. And I'm going to evaluate the patient in parallel, but I may not have seen them yet. So I try to set those expectations up front before the initial presentation, so that I let them know not only what I expect in the presentation, but why it's so important that they present to me in an organized fashion and how I expect that to roll. And then I may even model that, but I also want them to practice or have their residents. So knowing where your learner is at and setting that expectation up front of myself and of them and the team, I found is super important. Next slide. So now if we go back to our SBAR, we've now admitted the patient, we've gotten that handoff from the ER. And so really the H&P, as you know, is that initial important summary of what that learner just encountered. So they are doing it in that organized fashion, and that it is not just a written format. If it's a written format, we all lose focus. And I tell them that it's important that you keep it focused, no extraneous and that you only include that information that both supports or refutes what your final diagnosis is. I tell them, think like you're a lawyer, that you're presenting a case. And so you are really making your case. And that's why it's so important that you practice ahead of time what you're going to say. Because if there's a lot of extraneous details, as you all know, especially in the middle of the night, we may lose our focus as attendings and go, wait, did they say that? Did they not? And if they start going off on a tangent about Aunt so-and-so who may have lost this or that, then we lose our focus. So it's important that you really convey to them the importance of this, not only for a kind of understanding from the team, but also so no medical errors are made. Next slide. So the chief concern is that brief one-liner, right? So that is in the patient, could be in the patient's word or a quick summary of what brought the patient there. 42-year-old complains of chest pain, the pertinent key events. So thinking about what that happened and the chronological nature. So we are already, that presenter is presenting a story in our mind. This is a 42-year-old who comes with a history of hypertension, coronary artery disease, and hyperlipidemia, who presents with 3 days of chest pain and shortness of breath. So what are those details that are important are those that all kind of can feed into what we think our final differential is going to be and explain why we want the plan that we want. So that's important, I think, to explain to our learner up front. It's not just that it's an pedantic exercise. This medical language is a certain language that we need to hear in that order, in that presentation. Otherwise, we can't make the correct analysis. So one way of, again, mnemonics are key in medicine. So one thing we can do is use the OPQRST. So when did this occur? 3 days ago. Sudden. What made it better? What made it worse? Quality. Was it radiating? Was it pressure? Was it burning, right? That all helps us create that visual in our mind. Where was it? Did it go down the arm? Did it go up the neck? Or did it just stay right there? How severe was it? Was it 9 out of 10? Again, this is all part of our language. Was there diaphoresis, right? We're all creating this image. And if a student takes us one way, then we might be thinking cardiac. Another way, we might be thinking GERD, and that can affect our analysis. What was the time course? How often before this presenting? That helps us interpret the labs. Next, review of systems, right? I always tell my learners, I want you to do a full review of systems. Let them know how much you want. An early learner, I may want them all because I want to know what they asked them. A later learner, I might say just the pertinent ones. Past medical history, again, teaching them what's pertinent, right? For chest pain, we really want to know, do they have hypertension? Do they have dyslipidemia? Do they have diabetes? I might not care that they had, their tonsils removed at age 11. What are their medicines? Again, tell them how much you want. Do you want the full list with the doses and family history? So again, it may not be pertinent that their great uncle, had lymphoma. So what is pertinent? Let them know because the early learner may not. Next slide. So social history, substance abuse, but also imparting the importance of the social determinants of health that may have contributed to this hospitalization. So we don't just blindly, we hear non-compliant. Well, why were they non-compliant? Let us know. You know, are they not able to afford their medicines? All of this, we can't really help the patient unless we know what brought them here. Sexual history, I usually ask for only if it's pertinent. If it's a 32-year-old with right lower quadrant pain, I want to know, right? And I want to know when her last period was, and does she have risk factors for STIs? Physical exam, this is a big one. As we talk about organization, right? This is where sometimes people start to go into assessment and plan, editorializing. Well, I think I think it's costochondritis. What's my pet's here? No. Just the facts, only the facts. So teach them to be very objective. Next slide. So labs. So again, how much do you want? It's important that you know what they checked. So be sure and tell them up front, do you want only the abnormals and the pertinent normals? So present what you think is relevant, but make sure you let your learner know how much you want, especially if they have a lot of labs, x-rays, and tests. The assessment and plan, I know many of you said that's where our learners go astray. So it's really important we help them organize that up front, that brief summary. How can they put that whole scenario, what just occurred, together in 1 to 2 sentences? 42-year-old with history of coronary artery disease and dyslipidemia presents with chest pain because of this, this, and this. My differential diagnosis is this, this, and this. And my leading diagnosis is this because of X, Y, and Z. I really encourage all of my learners, even the 3rd-year residents, I want to know what you're thinking so that I can help make sure that we're on the same page. That helps me. Why did you not go down this route? They may have asked them something that I didn't hear about in the HPI. So what are those things that you think make your differential more or less likely something? And so this, again, is you're the lawyer. You're making your case for why you decided to order a cardiac cath for the next morning, or why you called the cardiologist in. So that is your plan. Why did you come to that decision on your plan? And what are the other, after that, most important first, he came in with chest pain, right? But he probably has a history of hypertension, say. So what is your plan to make sure you address that, even if it's well controlled at that time? Again, always let your learner know, especially sometimes if you're in the ICU setting or another setting, you may want systems format rather than a problem-based format. Please let your learner know that up front, and then you'll get a better result. In terms of the IPASS, this is then, you've got the admitting team, they're going to do their handoff. We know errors of care can occur in the handoff. So IPASS is a nice mnemonic then to let them, when the night team comes on, to make sure they say upfront illness. This is a watcher. He's got chest pain, coronary artery disease. He just came back from a cath. Patient summary, that's your brief one-liner, but that illness setting up front so their eyes are like, oh, wow, this is a watcher. Oh, this is a critical patient. So they have that mental image and they're really tuned in what you want them to do. If this occurs, let them know. You as the handoff person, instruct your learner. If they're the handoff person, let them know what you want them to do. Anticipate what the situations could be. And then the teach back method, right? You want to hear from the person receiving it, what they just heard. This is a watcher. This is what I'm going to do with X, Y, and Z. I really try to observe all of my handoffs as much as possible on my inpatient week, so I know that there's no errors and that everybody's on board with how they present the handoff and how they receive it. So that is a really distinct type of oral presentation. And then next slide. So this, again, just summarizes what I said. And I know in the interest of time, we'll just kind of fly through these last few slides. And then next, so this is an example of the IPASS in this situation. What are each of those things that then you can repeat back? This has actually been documented to decrease medical errors and transitions of care. Next slide. The follow-up presentation, SOAP, just like if those in the outpatient clinical setting, this is probably the thing we use the most, right? So it's also used sometimes for the next day. Subjective, teaching them what that subjective is. In the hospital setting, we may be getting it from the nurse, so say that. But also any overnight events that happened, right? If that patient they had a drop in their hemoglobin, you want to say this, and then do what the patient is saying. Patient reports less pain overnight, decreased swelling, not just no acute events, right? We want to know what they asked them. So be sure and tell your learner that. Again, the objective, just the facts, only the facts. Their assessment, this is just your one-liner, again, that summary, and then their plan, typically in problem-based order. Number 1, chest pain, plan, cardiac catheterization today. Number 2, hypertension, well-controlled, continue this. If it's another setting, you might do systems-based, but this is kind of the same format we'd use in the outpatient setting as well. Next slide. So in summary, as we said, the effective oral presentations, they're organized, they're succinct. You want good voice modulation, good eye contact. Have them just practice till they're blue in the face. Have them get up on Zoom, record themselves, say it in front of a mirror to their resident so that they're ready to go. They should include the content, organization, and length that's specific. Back to VJ's point, let them know ahead of time. They might have just come off a surgery rotation where 1 minute was fine. You're in internal medicine setting, you say, I need more detail. This patient's got more complexity. Let them know, and let them know where your learner's coming from and what your expectations are. As we said, that's dual. We've got a dual role here, right? They're both helping us. We're assessing their knowledge base and assessing them, but we need to know because we are diagnosing the patient and ultimately they're under our care. SBAR, IPASS, SOAP, all of those are effective tools. There's nice laminated cards, other things that you can use to really help your learner remember. And if I have a student that's struggling in their organization, I actually have them do a handout. And so every day they already have a pre-printed format SOAP and actually have already pre-populated that. So they're constantly having reminders of what that organization is.
Barbara, can I have
Yes.
one more minute? One more minute.
Okay.
I just want to summarize what Dr. Buss said. So it's all boils down to whether your learner is connecting the dots correctly, right? Because you want to go backward and see whether he's clinical reasoning, because I saw in a survey, majority have a problem about assessing their data interpretation or clinical reasoning. So dive deeper into whether they are connecting the dots properly backward, right? Because that will help you. If they're not connecting dots backward properly, then inconsistency, then you have to fill that knowledge gap in their clinical reasoning. So that's very important. And I think Dr. Burke said very quickly, but I will stress that again, asking why is the most important. There was a professor at Harvard, maybe 40, 50 years ago. He will ask 8 or 10 why. So if you say, I have a pneumonia, I said, why you have a pneumonia? So he was a smoker. So why he was smoking? Because he got addicted. Why he got addicted? You can go from a macro level to the micro or a DNA level. So my 2 key points here, see whether your learner is connecting the dots properly. If they're not connecting dots proper, find out inconsistency, fill up the gap with the knowledge, and keep asking why question. That's the only way you can make the learner better. And I want to thank Barbara and Michelle and Dr. Fine or Lorraine. Thank you all.
Yes, thank you. Thank you, Dr. Michelle Birch, Dr. Lauren Fine, and Dr. Vijay Rajput, and to all of the people who have joined us today. The recording will be on the .com YouTube channel very shortly, and please contact me if you'd like a trial subscription to .com. My email address is here. No credit card is necessary, or if you'd like a limited free subscription to Professional Formation. Thank you very much.
Thank you all.
Thank you.